Dear colleagues, good day. Let me express my special thanks to Professor Kataev and my hot best wishes from Moscow. Outside is 35 degrees Celsius to my Indian colleagues. I am going to discuss today some aspects concerning human herpes virus type 6 and its critical role in ordinary keratitis development. So why do we speak today about this virus? May play some special role in keratitis development, despite the well-known fact that herpes simplex virus type 1 is considered to be the most frequent etiology agent for herpetic keratitis. So, in contrast to coronaviruses, external aggressors, herpes viruses are long-life guests in our organism. And Professor Hendricks gave them exact definition. Once got into our house, they never leave it. These characteristics, without exaggeration, we may attribute to all 8 herpes viruses. No doubt, polymerase chain reaction, PCR, is a precise and useful tool for herpetic keratitis diagnostics. In modern world practice, herpes viruses are detected either in tear fluid or in corneal scrapes in cases of presumed herpetic keratitis, and in anterior chamber fluid or even in vitreous in cases of herpetic uveitis or, for example, acute retinal necrosis. Many authors consider PCR screening, total PCR screening for 6 or 7 herpes viruses, except human herpes virus 8, should be held. Robert et al. In 2002 published the results of the first successful attempt of multiplex PCR use by corneal inflammation. After him, many authors from different countries started exploration of PCR possibilities by herpetic keratitis, keratouveitis, and endotheliitis. And the most representative I found for this presentation were Sugita 2013 and Nakana 2020. Dr. Jovetta Joseph and al. It's quite recent publication in Indian Journal of Ophthalmology 2019 concludes that quantitative PCR method is extremely informative by herpetic keratitis. Dr. Manisha Achraya from New Delhi also supported this point of view, pointing out that PCR acts as a powerful adjunct in diagnosing viral keratitis, besides, however, careful history taking and clinical exam. But what in fact has turned me, being an ophthalmologist, towards herpes human virus 6? My own research results. As you can guess from these graphics, it reflects 6 herpes virus detection rates in tear saliva by herpetic keratitis of long-lasting protracted course. As you may see, human herpes virus 6 has the highest rate by this condition in tear and saliva. But why? Herpes simplex virus establishes its latency in trigeminal ganglion. It's a well-known fact, as well as varicella zoster virus. After varicella infection or after varicella vaccination, it harbors in trigeminal or dorsal ganglia. But where does human herpes virus 6 lives? Let's get some information from pathologists. Katarina Höfner et al. 2007, using nested polymerase chain reaction, determined this virus in different ganglia, including trigeminal. Moreover, it co-occurred with herpes virus simplex virus type 1 or varicella zoster virus in 91% of material. Erin Herberts et al. Detected human herpes virus 6 DNA in nasal mucous samples, showing the nasal cavity is a reservoir for this virus. And finally, Evona Plazhinska-Sarosek et al. Found DNA of all 6 herpes viruses in trigeminal or facial ganglia of cadavers. But human herpes virus 6 was the most prevalent of all herpes viruses. And this fact clearly, partly clears why this virus has the highest rate in my investigations. Comparison of human herpes virus 6 detection rates in healthy versus patients with herpetic keratitis shows significant difference between these groups, 7.4 in healthy versus 45.8 in herpetic keratitis. Moreover, human herpes virus 6 viral load by quantitative PCR in tears and saliva significantly differs in these groups by Mano-Whitney for independent samples and by analysis of variations. A role of this virus in eye inflammation development has been widely discussed in literature since the first publication in 1999 by Quavi till publication by Onda in 2019, who reported a clinical case of endotheliitis development caused by this virus after intravitreal injection of ranibizumab. In order to imagine how this virus may act in case of herpetic keratitis development, let's discuss a small clinical example. A 35-year-old Caucasian woman, contact lens wearer, had long-lasting complaints, pain, blurred vision, tearing, photophobia for the period of 6 months. And as you can see from this picture, she has a persistent, round, clear corneal ulcer with cratered shaped bottom. She has got short courses of acyclovir per os previously. In general status, nothing special except chronic tonsillitis. We performed quantitative PCR and in tears, saliva, serum, and urine. Varicella zoster virus and human herpes virus 7 negative everywhere. Relatively small amounts of herpes simplex virus and cytomegalovirus, probably due to short courses of nucleoside analogs previously, and in all 4 biological secrets, human herpes virus 6 with maximum in saliva, 64,000 copies. She was treated with intravenous acyclovir plus famciclovir per os. A local therapy include tropicamide, lubricants, and bromfenac twice a day. Already in 10 days, we have observed epithelialization, granulation tissue instead of crater-shaped ulcer. But what we have got in PCR? At the same time of obvious clinical improvement and fine general status, quantitative PCR showed elevation of viral amounts in all biological secrets except saliva. In saliva, twice a reduction. Systemic antiviral treatment has been continued, so in a month we achieved finally complete epithelialization. As you can see on these graphics, we have elevation of this virus in all secrets except saliva during therapy, and then gradient reduction of viral load to the moment of recovery till undetectable amounts. Red line, saliva load, yellow, blue, and green, tears, urine, serum. Since we understand that PCR detects namely viral DNA, so higher amounts during antiviral therapy may reflect status of massive presence of viral DNA, but not viral replication in biological secrets due to massive destruction of infected cells during antiviral therapy. Moreover, these lab findings were observed along with clinical improvement. Initially high human herpes virus 6 amounts in saliva taken into consideration with chronic tonsillitis in this case may reflect the viral location and source for eye inflammation. All the more, human herpes virus 6 amounts in saliva seem to be pretty high even after achieving recovery. So let me make some conclusions. Human herpes virus 6 is a serious pathogen, usually underestimated by ophthalmologists. Long-lasting course of herpetic keratitis may be conditioned by this virus by its production in trigeminal ganglion. And successful outcome should be achieved by high dose of intravenous or per-os antiviral therapy for at least 4 weeks. And local therapy should include mydriatics and lubricants.